Hello. I will try to present an example on Zostavax vaccine, and I hope to be able to surprise you towards the end after I said that, this study is perfect, then I will prove it is not perfect, and then I will prove again that it is perfect. Anyway, I have to admit that when Steve Anderson, Rich Platt, and others suggested that I made a presentation, they asked me to present something completely different, which is a more classical study of the comparative effectiveness of influenza vaccines, high dose versus standard dose. We published in Lancet for the years 2012-13 and 13-14. I have reached a point in which I'm bored with that subject. We found results very similar to clinical trials, and I decided to suggest something with the support of my team and the support of our boss, Steve Anderson, who is hiding there somewhere, and who is the one who allows us to do daring things sometimes in methods development. I hope this will be useful. Despite the fact that Steve has seen the slides, has approved them, whatever I say, it's my responsibility. Steve is not responsible for it. And basically, what we did is try to determine the effectiveness of Zostavax vaccine, but the comparison group is the unvaccinated individuals in Medicare, which is difficult. When you compare vaccine 1 with vaccine 2, both of them are vaccinees. It's easy picking because the biases are lesser. When you try to compare vaccinated with unvaccinated, then you're in trouble, and we did get in trouble with this study up to a point. So we used Medicare beneficiaries, Part D beneficiaries who were eligible to get free vaccine. And the outcomes was everything in regard to herpes zoster outpatient, herpes zoster, ophthalmic zoster, PHN, and also hospitalized zoster. So everything we could get our hands on in regard to herpes zoster outcomes. After matching, we use cost regression models to estimate herpes zoster and PHN risk. We adjusted for known characteristics. Everybody does that. And we measure the risk at different times using COGS, assuming duration of vaccine protection does vary over time. I'm not going to present that data, but yes, vaccine protection does vary over time. Then we decided to get the decision aid that you have been developing and try to respond to those questions. I will be very summary for the first 3 questions because I'm more interested in the unmeasured confounder bias. So the clinical and epidemiological justification, there are questions regarding effectiveness and duration of effectiveness. Despite numerous clinical studies performed, we proved that point. PHN had not been studied at that point in a randomized study. Hospitalized zoster had not been studied in regard to Zostavax effectiveness. Now, did we register the study? At this point, we have not. We prepared the protocol. We analyzed it in our team. And we are regulators, and we decided that that was enough for the time. But Steve and others at FDA are discussing ways in which we should register protocols before implementation. This protocol particularly was not registered before implementation. We have presented it a couple of times, including to manufacturers. How did we structure the report to enable replication? Well, we simply put in appendix all the covariates used. So we published it in CID in 2017. In the appendix, you have all the codes we use, all the covariates we used. And in supplementary materials, you have all the analysis and sub-analysis we did for all the groups. Now, let's get into the more interesting part. What's the balance before and after matching? Did we address and measure confounders or not? Was there a good balance between cohorts? We adopted a classical approach now by Rubin and Thomas, in which we combine propensity scores and Mahalanobis distance. Propensity scores for a huge number of covariates, Mahalanobis distance, which can be used not only for continuous variables, but you could add discrete variables using quadratic equations. And then we got a much tighter match, which I hope I will prove to you. And then to be able to adjust for the heterogeneity between vaccinees and non-vaccinees in regard to key covariates. So this is a very small summary of the variables. More than 80 variables were used. And towards the bottom, you will see the important one, which is the one we use Mahalanobis distance for. And in this two-step approach, I hope I will convince you that we got a good matching. So because there were approximately 1 million herpes zoster vaccinees in the fee-for-service database for the years 2007 to 13, but we had almost 7 million unvaccinated individuals, so the vaccine coverage was not very high. That gave us the opportunity to have the luxury, I would say, of doing a one-on-one match, keeping our vaccinees and trying to get the unvaccinated to come to us and match to the 1 million vaccinees. So we lost very little, very small number of unvaccinated individuals. So one herpes zoster vaccinee was matched to one control with the Mahalanobis, the smallest Mahalanobis distance after having performed the propensity scores. We use, because we use a very, very large sample, we use standardized mean differences to to determine the balance of the cohorts. It's less influenced by the size of the cohort. And did we sacrifice generalizability, utility? Well, one thing we did is we lost most of the unvaccinated. So this data set we use is no longer representative of the universe of the unvaccinated, but hopefully I will be able to convince you that this still is representative of the universes of vaccinees and a matched cohort that goes with it. So the evaluation we did is an evaluation of average treatment effect, the treated at the vaccinees, because out of the 1 million vaccinees, we preserve almost all of them. We only lost 1% of them. So the average treatment effect could be considered valid for the vaccinated. But we cannot say the same thing for the whole population or for the population of unvaccinated. So we dropped more than 5 million, almost 6 million unvaccinated. So this is the propensity score distribution pre-matching. As you can see, there are two lines. This is the unvaccinated, not well matched with the vaccinated cohort, which is around 0.15. So this is beautifully centered, and this one is not as expected. So there are, before matching, the populations are different with respect to key covariates. We need to do something. Propensity scores, Mahalanobis distance is what we decided to do. This is just to illustrate the cohort match. To give you an idea, because the previous graph could look awfully unbalanced, but the difference were not really dramatic in regard to numbers. For instance, the average age was 76.61 years, and in the unvaccinated, 78.6 years. So not so different. And this population is older than the Medicare population because we require people to be in Medicare since 2006. So this is an older cohort. This is not a typical Medicare cohort. It is older. So then we match, and then post-match, voila, the miracle of science, right? The two cohorts are wonderfully, consistent propensity scores, Mahalanobis distance, miracle, and then we look at the age. The median age is 76.61, and this one is 76.6. So it's not exactly matched, but I don't know how many clinical trials can do that. So we also created a number of covariates that I insisted my team to work with, which is what happened the previous year. How many hospital visits, ER visits, physician's office visits, things that have to do with health-seeking behaviors. And as you can see, as you can see, the Austin standardized mean differences are almost zero for everyone. So among all the covariates we analyzed, and I'm not going to show you all of them, the Austin standardized mean difference were less 0.03 or less. So we really had a wonderful cohort, well matched. But we have the problem of unmeasured confounders, which everybody has, right? What did we do? In regard to unmeasured confounders, we, besides using the primary analysis, we decided to compare the herpes zoster vaccinees with a cohort of people vaccinated with another vaccine. This other vaccine was pneumococcal vaccine. Why did we choose pneumococcal vaccine? It was really arbitrary. You could challenge that. Also, we use something that many people here have used in ways that are much more sophisticated than we did, people in Sentinel, etc., in OMOP, we only use 13 negative endpoints to check the balance of the cohorts, assuming that for those negative endpoints would cluster around 1, no difference between the groups. Why 13? It's a nice number. We got it from a paper published in JAMA by Zeng, Harpaz, and others, and Rafael Harpaz was one of our collaborators, so we use his method. So we run this, and we'll try to spend a minute or two on this. So here we have the no difference, and these are the 13 outcomes. These 13 outcomes have two colors. The primary analysis, which is the comparison between the vaccinated and the unvaccinated, and in gray, the secondary analysis, which is the comparison between the vaccinated and the pneumococcal vaccinees. You could argue that the vaccinated pneumococcal vaccinees comparison clusters a little bit better around 1. At least that's my religious belief. And then our estimate for the effectiveness of herpes zoster vaccine is significantly different from any of those estimates. Therefore, I could argue that we have proven that our estimate shows some effectiveness, right? Which could be if everything I said is true, which I hope it is. Now, since publication, we were given more resources by Steve Anderson to explore this further, and I was informed by Jeff Kellman that we had a survey in Medicare, and then I said, let's use that survey to check the match of the cohorts and see what happens. So I hope I will be able to surprise some of you. So the Medicare Current Beneficiary Survey is a survey that is performed every year among a random sample of Medicare beneficiaries. Some groups are oversampled, the disabled, they're very old, but it's a random sample process. We could argue that this survey, because it addresses questions regarding health utilization, do you like to go to the doctor, et cetera, frailty is a good sample, and that the data that are missing here are missing at random. Then we ran a cohort comparison using the survey, and after matching, in black, I will only focus on the after matching, we compare the 1,900,000-something vaccinees with herpes zoster with 900-something non-vaccinees. And among them, there were in each group around 1,800 people who had been in the surveys. And we checked the match of covariates that were in the survey. Questions like, do you like to go to the doctor? Would you do anything to avoid going to the doctor? Do you like being vaccinated, etc.? And we matched them. And we saw that some of them, this is standardized mean difference. So to the right is less balanced, let's say. But some questions were unbalanced. All of them, the others, and there are 100 of them, were very well balanced within the standardized mean difference limit of 0.1. But these ones about likelihood of using health services for prevention, vaccination, etc., and the level of education were not very well balanced. Nothing dramatic, but not perfectly balanced. And then we ran it for other covariates, as I said, all of them much better balanced. I will not bore you with the whole list of covariates created by the survey. Now we try to do multiple imputations. Instead of using univariate imputations, people now use multiple imputations, chain equations, etc. I will not waste time on that because I have 6 minutes. And then we linked some of the responses. Why didn't we use all of the responses? Well, there are statistical reasons why we didn't want to go with too many responses. So we chose responses that, in our judgment, were representative of the problems we had found, which is avoidance to go to the doctor and level of education. And we also used difficulty walking, the answer to the question, do you have difficulty walking? Because it was highly prevalent. There was a 20-something% response on I have difficulty walking, so it gives us some power, right? And then because we are always afraid of frailty and those kind of things. So we chose this in a way a little arbitrarily, but a group of social scientists, etc., selected it. And then we decided to know, can we not only check the balance, which we did between the two cohorts, which was fairly good, as I said, after matching, but create a new covariate, meaning these three variables represented 1,800 of each one of the million individuals in each of the two groups. Now, can we extrapolate data from them, and by using multiple imputations, create a new database of almost 1 million individuals each side, in which we will know whether these people like to go to the doctor or not, highest level of education, etc., using the correlation with other covariates. It was very daring, so we ran simulations to try to see whether it was possible. And this is let's say, in this simulation, this is the perfect, well-balanced study, centered around the true value, very thin, with X1 and X2 covariates. We are going to make X1 disappear, and this is the, let's say, bias estimate. Still very precise, but bias. Then we analyze the survey population, this much smaller survey population. Very precise, very well centered around the true value, but huge variability because of sample size. Then we perform imputations using chain equations. We use two approaches, very similar. You don't see the difference between them. And this is the linked population. And the precision of the estimate was increased. So we said, let's run the multiple imputations. To make the story short, we did it not only for this estimate of effectiveness of the vaccinated versus the unvaccinated. We also use something that I personally like more, which is effectiveness of the vaccinated versus the unvaccinated for an outcome which also included the use of antivirals in a comparison between vaccinated and pneumococcal vaccinees, which I'm not presenting here because of lack of time. But basically, the estimates for both analyses are very similar. We increased the confidence intervals a little bit, but we did, after adjusting for these three covariates, walking difficulties, likelihood of going to the doctor, and highest level of education. So what did we learn from all this? A number of things. This decision aid helped us go through this process. So I think it's basically a useful tool. It was useful in this exercise, I think. Then problem and measure confounders. I think we have to dedicate the rest of our lives to measure confounders. Health-seeking behavior, frailty, others, we have to find ways to address them. I have given you an option, which is the use of multiple imputations for a survey. You could, I was discussing with Rich Platt a few minutes ago, you could create a survey of a small sample of any large database you have and do the same thing we did. We didn't have to create or pay for the survey. We are, piggybacking on somebody else's work, but it could be done in any database, and I argue that at least to check the cohort balance, it's a worthy effort. Then, of course, we use negative endpoints, but you have discussed about that significantly. You know the good, the bad, and the evil of that. I will not, dwell on that. And there have to be other things to do. Now, regarding our use of MCBS, in the minute I have, I will tell you that it's not so perfect. Some of the responses change. When the same person is interviewed over time, some of those responses change. Not about level of education, which seems to be very consistent, but about difficulty walking, even likelihood of going to the doctor. People either change opinions or change the response. That, as in my discussion with Rich Platt a few minutes ago, he agrees with me, I hope, Rich, I'm not putting words in your mouth, that these inconsistencies, when you use them well, they are information. The fact that I give inconsistent responses to a survey as the same way by professionals, that is information. So use that information, and we did, I think. There is noise in MCBS because of this and also because of the sample size. And there is a bias variance trade-off when linking, so you have to accept that. And these are the main people in the team, and as I said, anything we do and we have done for the last few years is based on the fact that Steve Anderson trusts that we will not deviate from the mean very much. So thank you, Steve, for giving us a resource. Thank you.